Good afternoon, everybody, and welcome to this Global Health Learning Network. My name is Jan Hatcher-Roberts. I co-direct the WHO Collaborating Center for Knowledge Translation for Health Equity, and Alison is a member of that Collaborating Center as well. And also I'm an adjunct professor in the School of Epidemiology and Public Health, where I teach global health systems. Before we begin, I want to pay respects to the Algonquin people, who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor the courageous leaders, past, present, and future. Thank you. So I want to introduce the Global Health Learning Network to some of you who may not be aware of it. The Global Health Learning Network webinar series is a collaboration between the School of Epidemiology, Public Health, and Briere Research Institute, the WHO Collaborating Center for Knowledge Translation, Technology Assessment and Health Equity, and the International Global Health Office, IGHO. Dr. Alison Krentel, who will be our speaker today, is an assistant professor in our School of Epidemiology and Public Health at the University of Ottawa, a scientist at Briere Research Institute, and an honorary research fellow at the London School of Hygiene and Tropical Medicine. She is a senior fellow at the WHO Collaborating Center, as I mentioned, for knowledge translation and health equity. And Dr. Krentel's main area for research interest and expertise involves around understanding and facilitating a community acceptance of new health initiatives for the control and elimination of infectious diseases, specifically neglected tropical diseases. She's one of the lead principal investigators for a study understanding the transition to scale of proven interventions to address female genital schistosomiasis in Ghana and Madagascar. So we're going to be a very interesting topic today, and I know some of her fellow researchers are online, so we welcome them as well. Over to you, Alison. Well, Alison will speak about 30 minutes, so leaving us ample time for discussion.
Great, thanks so much, Jen. Thanks for the opportunity to be here. And I just want to welcome my fellow Fast Package colleagues on the line from Ghana, Dr. Apare and Maxwell and Mustafa from the University of Health and Allied Sciences, and from Madagascar, Dr. Mbola Tina from Association Kolavanona. And there may be others that I've missed. I haven't scrolled through everything, but welcome. And obviously also Kazim Arugandade, who's our project coordinator at Briere Research Institute. So I'm just going to share my screen here. Hold on just a minute. Let's see. There we go. Sorry about that. I think that I would have had this ready. Okay, there we go. Somehow it's not. Okay, there we are. Hopefully is that on?
Yes.
Okay, wonderful. Great. Okay, excellent. So thank you very much for the opportunity. And I'm really delighted to be representing some of my colleagues on the line today, and I'll invite them to be part of the Q&A at the end. So I'm going to be presenting on the FAST package, which stands for FGS Accelerated Together. This is a project that's been ongoing in Ghana and Madagascar over the last 2 years. And I'm calling this a baker's dozen of key findings. So for those of you who are bakers, you're going to go, oh dear, she's going to go on forever. But I do have 13 kind of key findings that I want to share with you from our work. So as I mentioned, I'm representing a much larger team here, our team in Ghana, from the University of Health and Allied Sciences, from the Ghana Health Service. They're also members of the FGS National Committee in this photograph, colleagues from the Schistosomiasis Control Initiative Foundation, and also from Bridges to Development. And then here on the right side from the Ministry of Health in Madagascar and from Association Kola Vanona. So the aim of today's presentation is to look at just briefly what is female genital schistosomiasis. Some of you who are on this call, you will be familiar with this topic, but I'm just going to give a very broad introductory explanation of FGS, and also look at why it is an important sexual and reproductive health issue for women and girls in sub-Saharan Africa. Then I'll introduce our approach that we used and some of the key findings. So what is FGS, or female genital schistosomiasis? It's a gynecological disease that is caused by untreated infection with schistosoma hematobium. And schistosoma hematobium is a parasite that's found in parts of sub-Saharan Africa. It's a disease that is caused by the migration of the schistosome eggs through genital tissue. And it actually, we also have a condition called male genital schistosomiasis, but today we'll be just talking about FGS. We estimate that there are between 40 to 56 million women and girls infected with FGS, and this represents approximately half of the women and girls who have hematobium infections. So in terms of the transmission cycle, infection occurs when the skin comes into contact with contaminated fresh water. It does not need to be a prolonged contact with fresh water. And at this time, the parasite enters in through the skin, and the adult worms then grow in the body and lay eggs, which are deposited in organs throughout the human body, and then eggs are excreted, and that restarts the cycle of transmission. And the fresh water, and a key part of the transmission of schistosomiasis is the presence of these snails. So it's not just any fresh water, but it's fresh water that has the presence of these snails. So there are two forms of schistosomiasis. There's urogenital or intestinal schistosomiasis, and that is determined by where the parasite is in the body. So today we're going to be talking about urogenital schistosomiasis, which is circled here in green. So female genital schistosomiasis is characterized by these following signs and symptoms: vaginal discharge, bloody discharge, bleeding after intercourse or spotting, genital itching, pelvic pain or pain during or after intercourse. And then the classic kind of sign really of schistosomiasis infection in general is bloody urine. And this is a known sign and symptom throughout sub-Saharan Africa, and often is associated more with boys because they see it more, and girls sometimes they don't recognize it because of menstruation. Upon a clinical cervical examination, the signs of FGS include cervical lesions, which have these abnormal features listed here on the right. An important part of the signs and symptoms, of course, is that there must be a history of freshwater contact in an endemic area in order to be able to make the diagnosis. Diagnosis can be done, as I said, by visual inspection, colposcopy, but it actually might miss some cases, particularly if there's disease in the upper reproductive tract. So generally, presumptive diagnosis is recommended based on signs and symptoms using treatment with praziquantel, which is a very safe drug. And also, diagnosing with a cervical examination in young adolescent girls is not recommended. So how prevalent is schistosomiasis in sub-Saharan Africa? And if you look here, these are the dark pink, and the red indicates areas of moderate and high prevalence. So you can see that areas across Southern Africa and West Africa are moderate, lots of moderate to high infection. In the districts where we're working in Ghana and Madagascar, you can see this are indicated by these X's here. So in Ghana, North Tong District and Weja are areas that are located close to large water sources. So the Volta Lake, and then also the Weja Dam, which are two of the largest freshwater bodies in the country. In Madagascar, Morondava here on the coast, and Sakara, two of the most of the highly prevalent areas in Madagascar. So why is this an important sexual and reproductive health issue for women and girls? And probably you're saying, well, Alison, we understand that from the signs and symptoms that you've just described, but it's important to understand that when a woman presents with those signs and symptoms, she enters often into a cycle of misdiagnosis and treatment. And so it should be noted that in our study sites in Ghana and Madagascar, and also in other studies that have been done in sub-Saharan Africa, we find that healthcare personnel have quite low levels of knowledge about female genital schistosomiasis. And so when a woman or a young girl presents with these symptoms, they are misdiagnosed as a sexually transmitted infection or a UTI. And so you can imagine a woman comes and she visits her local health post, her rural health post. She's sent to pick up treatment at the pharmacy, and she finds that her symptoms do not resolve. And so then she continues to move up the cycle through the health system to the primary healthcare level, and then even to the tertiary level, where she may see an OB-GYN continuing to perhaps face misdiagnosis and treatment, with some of the more severe cases, including hysterectomy for women who have been seen with FGS, actually. At each of these points, of course, there's a considerable expense of unnecessary tests, surgery, and time away from home. So some of the other impacts of FGS on women and girls include an increased risk of HIV and HPV infection. In fact, we estimate up to 3 times higher risk of HIV infection. There are also risks of infertility. So complications can include difficulty to become pregnant, miscarriage, spontaneous abortion, ectopic pregnancies, which of course include a risk of death. There's a mental health component as well to FGS, and I'll talk a little bit about that with regards to stigma, but the depression and social isolation that can come from having a condition that is highly stigmatized and is actually you're having difficulty to receive treatment. So what is the fast package approach, and how does that fit into the problem of FGS, its prevalence, and its importance for women and girls? So what we noted when the team came together to think about this project and to think about what it would look like, we noted that there's a lot of activities that have occurred around FGS and research that has been done, but they tend to be independent of each other. And you may find a clinical study that is done that is separated from the connection of mass drug administration. For those of you who are new to the neglected tropical disease field, we use mass drug administration to deliver preventive chemotherapy in areas of high endemicity and moderate endemicity. So it's through this mass drug administration that we're able to reduce levels of infection. So we looked at these different innovations and activities that have been proven to work on their own. And we thought if we pulled them all together into one package, we would be able to provide a more holistic approach to address FGS that would be grounded in the health system. And all of this is supported by FGS national committees, which I'll speak a little bit more about in a moment. These committees are seated at the NTD programs in the Ministry of Health, who serves as a secretariat for their activities. So when we thought about the FAST package, not only are we thinking of a holistic approach, but we're also trying to think across the life course of a woman. So at the top of this table, you can see over time from birth until later life, there are different exposures to schistosomiasis infection. And remember that a woman and a young girl in many of these settings, because of her gender roles in a household, is going to be going to a freshwater source, a river or a lake, to collect water, to swim, to wash clothes, to bath. And so at different points in her life, she's going to have a variability of exposure to that fresh water. So highlighted in red are those areas where we see the FAST package intervening through its activities at different points over the life course. So the approach that we used an implementation research approach, and this implies that the research team in each country, together with us here in Canada, we worked very closely with the ministries of health in both countries. And an implementation research approach also means that as the research results are being put forward, that they're actually being fed back into the program. We used mixed methods research at both baseline and endline, and you'll see some of the methods that we used, and I'll be drawing from these results as I share the key findings. Interventions were carried out through the health system, and the training approach that we used both an online format as well as a face-to-face format, and I'll be talking a little bit more about that. We had technical collaboration with WHO, Afro region, as well as headquarters, and the establishment of a global technical advisory committee. This is just a summary of the REB approvals. So a few key findings, and again, don't worry, I won't spend hours on this, but I just want to highlight really some of the important things that we've learned over the last 2 years. So these are the 13 I'm going to highlight, and I'm going to go through them based on where they lie in the FAST package puzzle. So I'll talk first about awareness at the community level, then prevention of new cases through mass drug administration, diagnosis as treatment, the training of medical personnel, and then I'll end with one of our key findings from the national committees. So on the community awareness side, we learned that the risk for schistosomiasis is high. And you can see here, this is actually taken from our baseline data. So we asked across the cross-sectional survey how frequently people used and accessed a freshwater source. And you can see particularly in Sakara district in Madagascar, this is quite high, and the highest across the 4 districts. And this is really due to the prevalence of mining in the region and small-scale mining. So members of the community spend a large part of their time in the river looking for sapphires. One of the things that we learned during the course of the research is there's a real diversity of risk. So we often think about fetching water or swimming, but other activities like car washing or baptisms are also opportunities that an individual may become infected with schistosomiasis. And just remembering also that it does not take prolonged exposure in water to get schistosomiasis infection. So we also learned that community members have low levels of awareness about FGS. So this, we've combined here both community members and teachers. And you can see in the green, we see the low levels across all 4 districts, with the exception of North Tong, where we actually had higher levels of information about FGS amongst community members. At the teachers, we can see quite low levels in Madagascar, and again, slightly higher for North Tong and Meja. We did see a shift in these numbers in the end line assessments, particularly in Ghana, where we went up to about 65.5% across teachers that we interviewed. But these, the low levels of community awareness about FGS have been shown in other studies in the region. People are highly aware of schistosomiasis. They have experienced the signs and symptoms. They understand about bloody urine, but they're not aware about this chronic manifestation of the disease. So we learned that the impact of FGS on women and girls is stigmatizing. And through a method called photo voice, we asked women to take photographs of what the signs and symptoms of schistosomiasis meant to them. And you can see here in this image of a latrine from Ghana, this woman writes, each individual needs a latrine. Lack of that in a household brings shame because we all eat and we need a place to free our bowels. Imagine having diarrhea that causes stomach upset and not having a latrine close by. See how uncomfortable you will be. This is just like having FGS and not getting treatment for it. It itches, brings some form of bad odor, and you can't even conceive. How can you be among people? It is a great shame in our society. And she's highlighting here this really important point about the infertility that's associated with FGS. And in both Madagascar and Ghana, several of the images that women chose related to the infertility associated with FGS. In Madagascar, the image was taken from the back of a health center, this kind of hidden spot that's kind of in the dark corners. And this is the conversation that was spoken during the focus group. This picture for us is those who are ashamed, who look at us and know of the condition that we have. And so we are embarrassed and we hide. We don't want to be with the others, but we'd rather be on the sidelines. So really talking about the shame and the stigma associated with the signs and symptoms of FGS. On community awareness, this is the last key finding on community awareness. We co-designed an educator's booklet seen here with our partners in both countries. And the Ministries of Health, the Ghana Health Service and the Ministry of Health in Ghana were very involved in the testing and the approval of this locally. And while that added time to our overall process, what it meant was that this booklet has now been incorporated into their national protocols for mass drug administration for schistosomiasis. So we distributed over 3,000 hard copies. And you can see in Ghana, both teachers and community members had increased awareness and increased sensitization of individuals because they had used the booklet. There are more, and Dr. Apare is on the line. He also was very active in promoting this using a soft copy across trainings in other regions of Ghana. So this is just unique to the region, the study sites in Ghana, the numbers that I've shown here. So when we move on to using preventive chemotherapy during mass drug administration, we found that there remain some persistent challenges to mass drug administration. There is food insecurity, and this was particularly acute in Madagascar, which you've been following the news, has been undergoing a period of drought for many years. And so we found that families were unable to give their children a full tummy before they took the praziquantel at school. And so in both countries, the focus of the mass drug administration is on school-age children between the ages of 5 and 14. So oftentimes if kids are unable to eat at home before going to school, they may not take the medications while at school. There's also a general fear around side effects from the treatment. But despite these challenges, over 100,000 school-age children received preventive chemotherapy with praziquantel during the project period. And this is a routine activity that's carried out by the neglected tropical disease programs in both countries and their partners. So the second key finding around MDA or the mass drug administration is that it appears that that boys access MDA more than girls. And so we asked who in your household has taken MDA within the last 12 months. And across all 4 of the study districts, we see that male members of the household are listed more than female members of the household. This is particularly important because regular treatment with praziquantel from an early age can actually prevent schistosomiasis from progressing to genital damage and some of the other related complications that I've mentioned. So this free regular treatment is so important as part of our prevention strategy of FGS and making that connection for members of the community, particularly for the long-term implications for girls with FGS. When we move on to our puzzle piece of diagnosis and treatment, one of our key findings was really to document the limited availability of praziquantel at primary healthcare centers. And these are images from one of the sites we visited in Madagascar, where if a woman is presumptively diagnosed with FGS from the signs and symptoms that she's presenting, she is unable to receive praziquantel at this site, despite the fact that it's on the essential drugs list for the country. So she'll have to take a bush taxi for 40 minutes to the local town where she'll purchase praziquantel for about $2. And bear in mind that the average monthly income for this region is about $40, $42. So quite an expense for her overall. We also learned with regards to diagnosis and treatment, we spent some time in both countries thinking about and asking about the indicator within the district health management information system. So reporting of FGS is very important because, as we've all heard this quote, what gets measured gets done. In Madagascar, there's no specific indicator for healthcare professionals to record if they treat a woman suspected with FGS. This will take some time to introduce into the system. In Ghana, the indicator was introduced through, in large part, through advocacy from Countdown, a large project on FGS carried out by the Liverpool School of Tropical Medicine several years prior. And so FAST really helped us sensitize on the indicator during the training activities. Reports on cases diagnosed over the project period are here. For Ghana, we've reported on the whole region, the whole country, based on really the work of the FGS National Committee and Dr. Opare in sensitizing about FGS across the country. And then the study, this is just for the study districts in Madagascar. So moving on to training, we used a really interesting online platform that's hosted by the Geneva Learning Foundation. And you have to remember that we started this project in July of 2020. So right at the height of the pandemics, there was no possibility of travel. And so this online platform was presented, and it's a really innovative way to approach training. And so we made this huge call across the region through Twitter, through our known contacts. Did any, register here to join a training on female genital schistosomiasis? We had over 1,500 health professionals make an application to partake in the training, which was beyond everything we expected. In the end, we were able to accept just over 480. Obviously, we gave preference to Ghana and Madagascar, but we were able to also include individuals from other countries in the region in order to also provide new opportunities for peer-to-peer learning. In the end, just under 200 health professionals completed the workshop. So the format that we used in the online training was effective. And you can see here across the pre-test in the blue versus the green here, the online post-test. You can see across all of these areas, there was an increase in terms of knowledge. We took what we did in the online format and we applied it to a face-to-face format. In both countries down at the district level, and we found that it was equally effective in terms of providing good training on FGS. And this quote at the bottom is really representative of what we heard throughout the whole training. Many health professionals would cite that they couldn't believe they had never heard of FGS, and they were, some even talking about seeing patients who they knew now had FGS and they had sent away because they didn't know what it was. So one of the features of this online training that was reproduced in the face-to-face training was the development of action plans. And the action plan asks the learner to create ways that they can leverage what they have available to them to increase awareness about FGS, to train their colleagues, to teach community members about it. So no additional funding is provided, but it's a way that they, within their own spheres of influence, can actually problem solve and improve the situation with regards to FGS. So over 213 action plans were developed during online training and 110 by learners in the face-to-face training. And you can see here on the right some of the countries where the action plans were created. Over 1,000 people were reported to have been trained by FGS scholars who came through the program, which is just extraordinary. We also had the creation of an organic creation of the FGS Society in Nigeria, which I've included the website here, which I'd encourage you to have a look at as well. So in terms of longer term sustainability, we really wanted to see the integration of FGS training curriculum into the health training institutes for sustainability. And so led by our partners, Bridges to Development, core competencies were developed for clinical training at the clinical and also the community setting. We use these to train subject matter experts in both Ghana and Madagascar, and we specifically identified individuals who were heads of training institutions or had a role to play in a training institution so that we could further promote this idea of adopting training within the curriculum. 4 institutes across the 2 countries will incorporate FGS training into their curriculums. The final key finding of my baker's dozen is really about the FGS National Committee. This was a committee that was supported through match funding from WHO ESPN, which is a project of the Afro office. And it's made up of individuals who are at the Ministry of Health, who can help to integrate FGS into cervical cancer screening and programming, family medicine, school health, women's reproductive health. So each of these committees, we have one is nearly launched in Madagascar, and the one in Ghana launched about 1.5 years ago. It's determined by who needs to be there in order to talk about integration of FGS in the country. And what we found in Ghana was this committee was able to identify new opportunities for integration of training, sensitization. There's also a lot of thinking outside of the box on how to make praziquantel more accessible in country. And one of the most interesting things for me to observe is the peer-to-peer learning that occurred between Ghana and Madagascar, and the sharing of lessons and experiences across the 2 programs. So some challenges that we noted throughout the 2 years. The availability of alternate water sources is poor in the study areas, and this makes reinfection seem inevitable. One of the nurses that we talked to, she said, even I have to use the contaminated water source. I don't have any options in this village. So this is, talking about schistosomiasis without talking about water and sanitation is really unfair, because we need to also be thinking about how to improve water and sanitation overall. The availability of praziquantel at the primary healthcare level does remain a challenge, and WHO has presented some options for countries to consider and some new guidelines that help countries to direct some of the praziquantel to women of reproductive health age. Both countries and the period of the project occurred during a very complex time. Obviously, COVID-19, I think everybody probably on this call has experienced a complexity in either healthcare delivery or research due to COVID-19, and we were not exempt from that either. We also had drought and climactic events, particularly in Madagascar, that we had to contend with, insecurity, and also other disease outbreaks that affected the delivery of mass drug administration, for example, in Ghana. We also, as a program, we probably over-relied on the annual Mass Drug Administration to sensitize the community on FGS. And given that COVID kind of upset the annual distribution of praziquantel, we found that we should have leaned more heavily on existing community health platforms to deliver information at the community level. We also noted that working through the health system, doing health system changes takes time, and donor reporting forms and timelines don't always conform easily to the time that it takes to work within the system. And one of the things we really learned in the online training is that we weren't prepared from an M&E perspective to capture the ripple effect of the training and the action plans, which was far beyond what we had expected. So finally, our next steps for the FAST package team and this initiative is to scale up this holistic approach to additional districts and new endemic countries. Also to respond to the global and national appetite to include FGS into health systems training, and just really noting this incredible demand for more knowledge and information. We'd like to further refine the FAST package to include a more robust community component. We really find that this will be important in increasing coverage with Mass Drug Administration, which provides that opportunity to prevent FGS from even developing. I've highlighted the ripple effects and the importance of capturing that and continuing to work with our in-country FGS committees and supporting them and also cross-learning across them. So finally here, just acknowledge all of those individuals who played a key role in the implementation of this research and this project. We had really a fantastic partnership that really started online, and we finally were able to meet in person in 2022. This project is supported by Grand Challenges Canada, and we had match funding from WHO ESPN, Merck Global Health Institute, Core NTD, the Geneva Learning Foundation, and SCI Foundation. So thank you very much.
Thank you, Alison. And I'm trying to make sure that I don't miss any chat comments, but please feel free now to ask any questions. Alison, did you want to introduce your other partners at this point as well? And
Yeah.
Kazim has raised his hand. So Kazim,
Okay.
or maybe Alison, do you want to introduce the other partners on the line? And then Kazim, go ahead and ask your question.
Sure, and I'll just invite if you're involved with the FAST package online, turn your camera on so that we can see you, and we'll make sure that we also shift some questions over to you as well. So I can see Dr. Pare and Dr. Mbola are here, and Dr. Mustafa. And others, so, and Kazim, Dr. Kazim. So please do turn your cameras on so that we can see you. Great.
Okay, great. Okay, and we've got some comments about great presentation, Alison. All right, Kazim. You have your hand up.
Thank you very much. Thank you, Dr. Krentel, for this excellent presentation. You did touch upon integration of trainings and at community level also. I just have two questions. One is it's now abundantly clear that NTDs and other diseases cannot be tackled in silos, and therefore integration across the board is the key. So what are the main challenges facing integration of FGS with reproductive health and health systems in general? And what can be done to successfully integrate FGS and other NTDs with the health system? That's one question. And the second one is, operational research is really important. And one of the factors that compounds the problem of operational research is the lack of resources. So what can integration do on this front also? Thank you.
Those are some really excellent questions. I would actually like to ask Dr. Pare, who is sitting at the Ghana Health Service, Dr. Pari, I don't know. Oh, maybe we just lost you. I'll just take a first hit at that, and then I'll invite him to maybe add something from his perspective as within the government on that. I think you're absolutely right on.
Alison, Dr. Pari's on now.
Okay, I'll catch him. I'll just start and then hand over to him.
Then he has to unmute. Yeah.
Okay, so Kazim, you raise a good point, and I think there's some excellent guidance actually with regards to FGS and integration, and I'd be happy to make that available through a guidance document that was done between UNAIDS and the NTD programs at WHO, which outlines the different areas where FGS can be integrated within the reproductive health frameworks. We know that, for example, integration with cervical cancer screening is so important. It's a perfect opportunity to see to look out for FGS, and so we know that FGS on its own we'll never reach where we need to be, but we actually have to integrate within the reproductive health, particularly within that platform, in order to reach anywhere on FGS. But I'll just hand over to Dr. Apare, just from the Ghana Health Service perspective, and he's the Deputy Director of the Neglected Tropical Disease Program. Kazim asked us, where are the challenges in integrating NTDs into other health system activities? And you're probably very well placed to comment on that.
Thanks very much for right. So that is the reason why in Ghana Health Service we have the FGS, and we need.
Are you able to hear Dr. Apare? If you could maybe speak up a little bit. It was hard to hear you, or maybe I'm the only one who just. Okay, go ahead.
Yeah, right. So thank you very much for the question. So that is why in the Ghana Health Service we have the FGS committee, and within the committee we have also the manager, the regional director for family health, right?
We're struggling to hear you, I think.
Is it better now?
Oh, much better. Yes, thank you.
Can you hear me now?
Yes, that's much better.
Yeah.
Thank you.
So I was saying that that is why in the female genital schistosomiasis committee for Ghana, we have the director of family health being part of this committee. So in order to make things easier, right, if the director of family health, okay, who is in charge of reproductive health, is aware of female genital schistosomiasis, then whenever there's education on STIs and other areas, this person will be able to propagate the essence of getting a female genital schistosomiasis into the equation, right? So it's about knowledge. Okay, it's about knowledge about FGS and the fact that what we normally assume to be sexually transmitted infection, schistosomiasis, can also be part, right? So it's about it's just further education that we did over here, and that is what the committee has certainly done. So there's no problem at all. We are educating the health teams right from the regional level, district level, on female genital schistosomiasis, because for schistosomiasis in general, they are aware of whatever is going on. But as we blend with female genital schistosomiasis, then it becomes better. So that's what I can say for now. Thank you. Over.
And I would just add, I would add to that one of the elements of the WHO's NTD roadmap for 2030 focuses on integration and recognizes that NTDs on their own in a siloed approach, we aren't gonna reach where we need to, and so we need to be thinking about more integration, and that's part of the goals towards 2030. Yeah, there's Dr. Mbola. Go ahead, please.
And then Alison, we have a question from Sam Aleo.
Okay, thank you. Go ahead, Dr. Mbola.
Yes, if you don't mind, I will talk in French.
You are in the Canadian audience, so you can. We are bilingual here, so go ahead.
D'accord. Juste pour parler de Madagascar, pour nous, donc, faire connaître FGS, c'était vraiment un grand challenge. Mais nous avons constaté que au cours, donc, on a fait une séance de restitution donc, à la fin du programme. On a invité tous les parties prenantes, donc, notamment les différents départements du ministère de la Santé et tous les parties prenantes donc, qui peuvent être donc, qui peuvent être touchés par le FGS. Et là, donc, on a vu qu'on a touché donc, beaucoup de choses, hein, parce qu'on a vu que il y avait plusieurs départements qui ont constaté que le FGS peuvent être vraiment, c'est quelque chose qui devrait être inclus dans plusieurs donc, programmes du ministère de la Santé, notamment de la santé de la reproduction, dans le programme de la santé familiale. Et là aussi, il y a eu donc à Madagascar la participation du secrétaire général du ministère de la Santé. Et ça a été vraiment, c'était a big challenge. Vraiment, on n'a pas encore vraiment, pour l'instant, un résultat vraiment concret, mais, mais on est vraiment donc très, on est très positif sur l'avenir donc de l'intégration du FGS dans le système. Et d'ici peu, donc, il y aura une mise à jour de l'ordinogramme qui sera utilisé au niveau des centres de santé de base dans tout Madagascar. Et au fait, moi, je suis membre de l'association, mais je suis aussi, je fais partie aussi du ministère de la Santé. Je suis d'un Institut national de santé publique et communautaire de Madagascar, qui est un département du ministère de la Santé. Et donc là, donc, on va l'équipe de l'association Poulvan qui ont travaillé sur le FGS va se battre pour donc intégrer le FGS, notamment surtout dans le volet STI, c'est-à-dire inclure donc dans les diagnostics différentiels le FGS. Donc là, donc, ce sont les défis que fait face Madagascar en matière de FGS, mais aussi c'est les perspectives et donc l'avenir que pourrait avoir donc FGS à Madagascar. Je vous remercie.
Merci, Dr. Mbola. I made a feeble attempt to translate some of your comments online. So, Jen, I think they're coming.
By Alison in the chat. So take a look, quite good. And then Sam Aleo wanted to know, was the medication administered in a DOTS way in the school? How was it administered? Directed of therapy or somewhere else in the schools?
Yeah, so for all of the mass drug administration programs for neglected tropical diseases, the gold standard is a directly observed treatment. So that is what is recommended for praziquantel. It's such a big pill that it's really important that it is directly observed, particularly for the young children. So it is an important part of the distribution. I don't know, Dr. Apare, if you want to comment at all on that from the program perspective.
Right. So as you rightly said, it's so we use praziquantel for the treatment, 600 milligrams per kilo body weight, and we get the supplies from the World Health Organization. So normally what we do is that after any MDA, the leftovers of the medication is left at the health facilities to be used for the treatment. Thank you.
Yeah, and this actually what Dr. Pari just mentioned was a really important thing that occurred during the course of the FAST package was we were able to go to Geneva, and we had meetings with WHO there, and really reiterated the importance of the availability of praziquantel at the primary healthcare center. And so through new guidance that's been issued from WHO on treatment of women of reproductive health age, the programs were also given clear guidance that they could use leftover opened containers, that they could remain at the primary healthcare center to treat women of reproductive health age and people who have schistosomiasis infection. So yeah, so that was another really important outcome of the project.
I don't see any other questions or any comments. Perhaps we could go to the poll, our evaluation poll, and you hopefully can see that if you have the version of Zoom, because we want to do the evaluation. But I did want to thank Alison so much for her presentation.
Maybe just before
any
we
other comments or questions.
Maybe
Yep.
just before we hang up, I'll just put the website in the
Right,
link
good.
here
Okay.
for people. If you're interested in knowing a little bit more about the FAST package and also seeing some of the, there's a video, a couple of videos that are up there as well. The training materials, there's a frequently asked question guide that's there. So please do check that out if you're new to this area and you're interested in learning a little bit more about FGS and the FAST package. So we invite you to check that out as well.
So it's fastpackage.org.
Yeah, just put it in the chat.
Yeah. Okay, fastpackage.org. Okay, oh, there's just a quick, that's yours going up there. Yeah. Okay, perfect. Okay. All right. Well, thank you so much. And amazing presentation. I learn every time I hear you, Alison. Area, but it's amazing, and such incredible partners you've got working in these countries that are really making it happen and hitting the ground with us and making these interventions work. So thank you so much. And now here's the session evaluation. If you can fill it out, and after this we're going to post next month's Learning Network presentation. We invite anybody part of this one to come to the next ones as well, because it builds a network of people with different perspectives. So if you could just quickly answer these questions.
In the meantime, while you put the questionnaire, can I ask a question to Alison, please?
Yes, please, Erica. Hi.
Hi, thank you. When you went to WHO, did you have a chance to talk to the Global Fund? Is there any ideas about integrating entities in the Global Fund? What is your sense?
Yeah, it's a really great question. So there is a lot of ongoing conversations that are being led by the FGS Integration Group, or FIG, and I don't see Felicia on the line here or anyone from Bridges. They've been very involved in that activity. So there has been conversations between Global Fund and the NTD department and this advocacy group. What Global Fund is suggesting, I think they're open to it, because obviously the administration of praziquantel has actually been declared by UNAIDS as an HIV prevention strategy, particularly in those areas where there's high to moderate infection of schistosomiasis. So, and there's an excellent UNAIDS document on that, which I'm happy to share. And so Global Fund is recommending that countries, through their country coordinating mechanism, put it in there. The administration of praziquantel or other activities around FGS before it goes to Geneva. So we do there is some openness to those kinds of, to the inclusion of FGS into Global Fund applications, but it needs to come from the country. And Erica, happy to put you in touch with some of the individuals that are having those conversations. I think it might be really valuable.
Thank you so much, Alison. Thank you.
So that question further speaks to Kazim's point about integration. So we have to be very creative also in the way that we fund things at the health systems level, and the issue of FGS and what other funding points we can access for this.
So Alison, sorry, Dr. Ari Bador wants to share the evaluation questions, is it?
Oh,
Or the overall evaluation?
Maybe it's not showing up.
It's share the evaluation.
I relaunched it, so I think everyone should have access now.
Yeah. Okay. All right. Okay. Yeah, I was having trouble as well. And then Alison sent a note to join the Next Learning Network December the 8th. And if you stay on, you can see the banner, which is very lovely looking, but there's the actual real information. So and people are thanking you, Alison, for a great presentation. There we are. There's the banner for next December the 8th, Understanding Mental Health and HIV Vulnerability in South Africa. And with Professor Duna, the Dean of Faculty of Health Sciences, University of Fort Hare. So that will be a wonderful presentation as well. So we want to thank everybody for being here, for being so attentive, some great questions. I'm sure we could have gone on for another hour. And please feel free to get in contact with Alison or our office if you want to continue to get these notices, or if you have any questions, okay, to carry on this dialogue. It's so important. And thank you, Alison, once again for this. Any last, no last comments? Wonderful. Okay, we have slightly less than half a minute, but I think we can close things down and let everybody get going. Lots of wonderful comments coming in. Wow, that's terrific. Thanks, everybody.
Thank you, everybody. Goodbye.
Thank you. Merci.
you.
Thank you.
Bye.
Merci bien.